Hello, everyone, and welcome to the February 2023 CNS Case of the Month. My name is Chris Newman, and I'm an assistant attending at Memorial Sloan Kettering Cancer Center. And today I'm going to be talking to you about a case on the management of symptomatic metastatic epidural spinal cord compression. The brief case presentation is that of a 64-year-old woman with a history of uterine carcinosarcoma who presented with 2 months of progressively worsening back pain. She was neurologically intact and described the pain as being worse at night and waking her from sleep. She underwent an MRI of the total spine with and without contrast. It demonstrated grade 2 epidural spinal cord compression at the level of T9. You can see those images here at the sagittal T1 post-contrasted image showing the epidural tumor causing some spinal cord compression, as well as the axial views showing that curtain sign with a little bit of dorsal CSF. She was evaluated by radiation oncology at the same time and felt that they did not have sufficient space between the spinal cord and the tumor to treat with radiation without giving her a high risk of toxicity from treatment. So when we think about how the approach to metastatic epidural spinal cord compression, in the absence of neurological deficits or mechanical instability, patients who have grade 0 to 1C epidural spinal cord compression, or those who have low-grade epidural spinal cord compression, can be treated safely with radiation therapy. Now, the radiation modality, be it external beam radiation or stereotactic body radiation therapy, is determined based on the tumor histology and its degree of radiation sensitivity. On the other end of the spectrum, patients who have high-grade epidural spinal cord compression, or those grade 2 or grade 3 patients, they're typically treated with some form of separation surgery, followed by adjuvant radiation therapy. The idea here is that by making space between the tumor and the spinal cord, you can give an ablative dose of radiation to the tumor while sparing the spinal cord toxicity. The exception to this is in patients who have exquisitely radiation-sensitive tumors, such as in small cell lung carcinoma or multiple myeloma, where radiation treatment still is and can't be the appropriate form of treatment, even in the setting of high-grade epidural spinal cord compression. In this case, the patient is neurologically intact with grade 2 epidural spinal cord compression or high-grade epidural spinal cord compression and a radiation-resistant tumor given her histology of uterine carcinosarcoma. In this setting, separation surgery was pursued prior to any adjuvant radiation therapy being given. When we think about what are the alternative approaches, I don't think that any of these are really good options for the patient. But when we think about them, they'd include upfront radiation with the caveat that there'd be a higher risk of marginal recurrence due to underdosing in order to avoid spinal cord toxicity. Observation would not be a good option here because the tumor will continue to progress under the current situation, and that would cause neurological decline and deterioration. And the initiation of a new line of systemic therapy, while it is something to consider in the post-operative setting, would not be advised due to the high degree of epidural spinal cord compression and the likelihood that it would take some time to initiate that therapy as well as to see the benefits of it, which could result in a neurological decline prior to seeing those benefits. When it comes to the actual operative procedure, the patient was positioned prone and on an open Jackson table. We utilized fluoroscopy to identify the appropriate levels, with T9 being the index level based on the degree of epidural spinal cord compression, and T8 and T10 being the levels for our pedicle screws based on the plan to go with a short segment construct. We made a midline incision spanning those levels and then did a subperiosteal dissection to expose the lamina and pedicle starting points from levels of T8 to T10. We placed those pedicle screws at T8 and T10 and utilized cement augmentation to increase their pull-out strength. Because really in the oncologic population, there was a large number of people who have poor bone quality with a lot of the hardware failure coming in the form of screw pull-out, amongst other ways that it can fail. Now in this setting, pedicle screws were placed given the fact that we plan to do a bilateral pediculectomy to get access to the ventral epidural space. Now, if we look at the screws, you can see on the bottom right side, the fenestrated screws that were placed, and then the cement that extrudes through those fenestrations at both the T8 and the T10 levels. Now, once we completed our T9 laminectomy, we then did our bilateral pediculectomies. When you do those pediculectomies, it destabilizes the patient's spine, and so that's why the screws really are necessary for this. Doing that bilateral pediculectomy gives you access to the ventral epidural space where you can visualize the posterior longitudinal ligament. And once you've kind of cut the posterior longitudinal ligament utilizing tenotomy scissors, you're able to visualize that ventral epidural tumor and resect it. Once we've done that resection, we then utilize intraoperative ultrasonography to confirm the decompression and make sure that we're happy with it. If you look at the top image here, you can see the thecal sac has been reconstituted with the spinal cord in the middle of that here. So regarding her postoperative course, she remained neurologically intact. She did get a postoperative myelogram where it shows reconstitution of the thecal sac, which you can see on the right side. At an outside facility, she had obtained a preoperative myelogram as they were planning to radiate her, and what you can see is a myelographic block that has been reversed by our surgery. Longer term, she received her stereotactic body radiation therapy approximately 2 to 3 weeks after surgery, and she received 30 gray delivered over 3 fractions. At her 6-month follow-up course, there were no signs of local tumor recurrence based on her MRI imaging, so we got good local control out of this. When it comes to the pearls and pitfalls of doing kind of separation surgery for these patients, really, when you're doing the resection of the ventral epidural tumor, you have to be exquisitely careful to avoid over manipulation of the thecal sac and consequently the spinal cord. Aggressive manipulation can result in spinal cord injury or even ventral dural tears that can be difficult to repair. Resection of the posterior longitudinal ligament with pneumotomy scissors is often necessary to gain access to that ventral epidural tumor that's really being bounded by the posterior longitudinal ligament. And intraoperative ultrasound is extremely helpful in confirming that you've achieved the desired decompression. Sometimes it'll reveal that you left a little bit behind, that there is still significant compression. And to get the best possible target for the radiation oncologist, I think that ultrasound really can be helpful with giving you that confirmation. If we look at this as a whole and really try to wrap this up, spinal metastatic disease is increasingly common in cancer patients. They're living longer due to better systemic therapy as well as better radiation therapy options. And in that setting, we are seeing more and more of this. However, the life expectancy of these patients can be quite limited. In that setting, we have to combine the aggressiveness of preventing disability with the consideration that excessive morbidity may not be something that these patient populations can tolerate based on their limited life expectancy. High-grade epidural spinal cord compression, that being grades 2 and grade 3, often requires separation surgery prior to undergoing radiation treatment. And that allows us to limit the spinal cord dose and prevent that toxicity while still giving an ablative dose to the tumor itself. And then when we think about radiation-sensitive tumors like small cell lung carcinoma and multiple myeloma, these are that exception where they really can be managed safely and effectively with expedited radiation therapy. But that always needs to be considered in conjunction with consultation with a radiation oncologist to make sure that they're in agreement with the plan of pursuing that radiation treatment up front. Also, cement augmentation really does allow for shorter segment constructs by overcoming the poor bone quality of many oncologic patients. And going shorter does allow us to have less operative morbidity with shorter operating room times, less blood loss, and the whole 9 yards of that. And then last, adjuvant radiation therapy really is the workhorse of this. It's providing definitive treatment of the metastatic spine disease, and it's essential to local control. Without it, the tumor will recur. And so giving the radiation oncologist an appropriate target to where they can really treat the tumor, give it that ablative dose, and get good control and good local control is essential to that teamwork paradigm of really being able to treat this effectively. So with that, I'll say thank you very much for your attention, and I look forward to seeing you at the next month CNS Case of the Month.